Do you know this cardiac device? I received multiple questions regarding what's the difference between pacemaker, ICD, CRT in the X-ray when we use or choose any of them. So I tried from simplified it from intensivist perspective view, how to use these devices, how to differentiate them in the X-ray and ECG. If it comes to the pacemaker, in the X-ray, it will be one or two smooth leads with no shocking coils. The generator is small and flat. Right atrial leads curve superiorly, and right ventricular leads go inferiorly toward the apex or the septum. This is dual chamber permanent pacemaker, where the generator is flat and small. There's two leads, the one toward the right ventricular apex and the other one toward the right atrium curved superiorly. And this X-ray, it's a dual chamber pacemaker with two leads coming out, one ending in the right atrium and one ending in the right ventricle, and we differentiated it like thin slim leads without any thickening inside them. The second device is implanted cardiac defibrillator, where the RV leads with radio-opaque coils segment or thickened white part appearing in the X-ray. Some ICDs have a second SVC coils, which is superior to brachiocephalic vein, and the generator is thicker and bigger than the pacemaker. This simplified diagram for ICD, where the ICD generator present in the left pectoral part of the chest or left chest, and we have two leads, one placed in the ventricle, where and at the end is thickened, shown thickened in the diagram, but on X-ray it will be like dark white coils for defibrillation, and the other one will be in the placed into the right atrium. And this X-ray, it's X-ray for ICD, and for this X-ray we will find that the ICD generator on the left side of the chest, and from this generator there is two leads coming out, and this is superior vena cava coil, and in the lower there is a right ventricle leads which direct towards the right ventricle or the septum, and the end of RV there is also RV coil. This is only single lead coming out from the ICD with two coils present on them. The coils representing the shock leads, which is thick, and representing the part which giving shock for the ventricle. Indication of ICD can be used as a primary prevention in patient who has ejection fraction less than 35%, despite optimal medical therapy in ischemic or non-ischemic cardiomyopathy, patient who has genetic conditions with a high sudden cardiac death, risk Brugada, hypertrophic cardiomyopathy, long QT. Secondary prevention in patient survival of cardiac arrest due to VF or VTAC, sustained VTAC with hemodynamic compromise. Understanding ICD on ECG, it's very important to know that the function of ICD not only for giving shock and VTAC. Sometimes if we have VTAC, the ICD acting as override pacemaker, and it's called anti-tachycardia pacing, where we during ventricular tachycardia, the ICD deliver anti-tachycardia pacing, which like short burst or ramp of pulse pacing pulse aimed at interrupting the reentrant circuit. So in ECG, it will appear like a rapid sequence of pacing spike, followed by return of sinus rhythm if successful. For example, if the patient developed VTAC with the ventricular response, for example, 200, so the ICD will be an anti-tachycardic with 220, so it will give these bursts or ramps to treat this type of tachycardia till the patient return to normal sinus rhythm. And pacemaker and ECG. baseline rhythm of we have patient on ICD. We often have the patient on normal sinus rhythm with no pacing spike, as only the pacing will be for backup. But in the pacemaker, especially if the patient is dependent pacing, so we will have regular pacing spike. And pacing behavior in ICD, it will be intermittent only if the bradycardia developed. But in regular pacemaker or permanent pacemaker, you will find continuous or frequent pacing depending on the programmed mode. In patients who have ICD, it can deliver anti-tachycardia pacing, short run of rapid pacing spike during VTAC, sometimes followed by rhythmic conversion. Pacemaker doesn't have no ATP function and only provide pacing for bradycardia or AV synchrony. The patient who has ICD uh, have large artifact during defibrillation shock if captured, and the ICD can give shock if the patient develop tachycardia, need to have a shock, depending on the programming of the ICD. In pacemaker, it has no shock capability. Lead characteristic on the ECG, we will show thick shocking coils in the ventricular leads. In the pacemaker, it will be 10 pacing leads only. The third part is cardiac resynchronization therapy, or CRT. We have two types, CRT-D, which has defibrillator coils like ICD, CRT-P, which have pacemaker function. So when we see in the ECG, we will have three leads: right atrium, right ventricle with or without coils, and left ventricle leads. The left ventricle leads laterally, posteriorly, and often seen in the face over the left cardiac border. CRT-D will have defib coils like ICD. The generator is largest due to combined function. And if we see this diagram for the CRT, this is the chambers, and left atrial leads, right ventricular leads, and left ventricular leads. Three leads are present with coils, so we will name it with coils. So the CRT will have defibrillator function. We will name it CRTD. I want to use cardiac resynchronized therapy. It's used for patients with heart failure, left bundle branch block, and wide QRS complex. Can be used for biventricular pacing, right and left, to restore the synchrony between the right and left ventricle. Also, it's combined with ICD function in some device. Will have a coiled leads, so to give shock for a patient with any tachycardia. Cardiac synchronized therapy, when we used, how can we use if we are what the characteristic patient with heart failure to have CRT? Broad QRS complex more than 120 milliseconds, and left bundle branch block morphology, which negative QRS in V1, wide notched R in V5 and 6. Also, that will help to improve right and left ventricle synchrony compared with RV pacing alone. If we comparing the CRT with ICD and pacemaker, we will find that generator of the CRT is the largest one, and we have three leads. The solid black one, which is right atrial lead, and the right ventricular lead, which is dashed black arrow, and the one in the coronary sinus, which is the red arrow. The coronary sinus lead wrap around the outside of the left ventricle, which enabling pacing of the left ventricle. I will summarize the three devices: pacemaker, ICD, and CRT, and I will summarizing their use. For a primary function of the pacemaker, it's used during bradycardia for pacing, and it's compatible with MRI. There is widely available devices compatible with MRI. Pre-MRI programming in some devices or some patients need to be VOO or DOO. And the X-ray is important to identify the device and the leads. During the MRI, we should use ECG monitoring and SpO2. And after MRI, we should using the programming to restore the primary setting and the integration of the pacemaker. The second device is intracardiac defibrillator or ICD. It's used for pacing and defibrillation. Also, MRI compatibility is model-specific limit, and pre-MRI programming, it's able tachytherapy, and besides it having pacing mode, in X-ray it can identify coils and abandoned leads. In ECG monitoring, it's mandatory with external defibrillator pads. After MRI, we need to re-enable therapy and restoring it. In cardiac resynchronized therapy or CRT, it's in function by ventricular pacing for heart failure plus defibrillation with or without defibrillation. And its most restrictive type, and it's need to be checked before shifting the patient to MRI. Pre-MRI programming like ICD, so we should enabling the shock and also ensuring biventricular pacing. In X-ray, we will identify all three leads with no abundant leads, and it's required beside ECG and SpO2 require presence of external defibrillator pads, and post-MRI we should check biventricular capture. In this table, I will summarize the whole lecture in this and repeat some important information. Sometimes we are at intensivist facing very important issue that we have patient in ER with a device in X-ray. We doesn't know what this device. Sometimes the device is affected or malfunctioning, so we need to know what this. If we come first to the pacemaker, permanent pacemaker will have the smallest generator. And from this generator, there is one or two leads come out. If the patient has two leads, one will be in the right atrium and the one in the right ventricle. The leads in the right atrium will be in right atrial appendage, and the one in the right ventricle will be directed to the septum or the apex. There is no defibrillator coils, which are representing in the X-ray by white thickening in the leads, and there is no LV leads. We should also check the X-ray well to see if there is abundant or fractured leads. And this is a contraindication for MRI. The generator position should be in the left, which is the usual position, left pectoral, but sometimes we have infection in that. Patient has a breast tumor, something like that, so we inserted in the right side. The most important in the X-ray, it's a slam leads, no coils, small generator. If we come to the ICD, we will find the generator larger than a pacemaker. From this generator, we'll have also one lead or two leads, but the lead which in the RV will have a coil thickening in the right in the lower part of the right ventricular leads, plus or minus right atrium. Also the tip position of the leads like the pacemaker, but also the differentiation between the pacemaker is presence of shocking coils or which is thickening at the end. In defibrillator, in X-ray coils, we will find radio-opaque thick coils in the X-ray, sometimes also present in severe vena cava coils. Left ventricle leads will absent. We should must check the abundant coils, which are and must check abundant coils, and must check also abundant or fractured leads, which are a critical risk. The same, the allocation of the generator will be left or right, as mentioned before. The clues for the X-ray coil segment, short thickened leads portion, which is radio opaque. If we come to CRT, which is the largest generator, especially in CRT-D, as it has multiple functions like pacing, defibrillation, and third lead. 3 leads, right atrium, right ventricle, left ventricle through the coronary sinus. The lead position like ICD plus left atrial leads that wrapping around the lateral posterior coronary sinuses. If the CRTD, it will have 1 or 2 coils like ICD, left lead present, left leads present posterolateral through the coronary sinus or really epicardial. Abundant lead frequently present failed coronary sinuses need review before MRI. The same for the location of the generator, left or right pectoral. And we should see the visual clue on the X-ray, third lead on the venous coronary sinuses over left atrial. Another important part for patient who has pacemaker and the patient develops tachycardia, and this tachycardia needing cardioversion. So for the pacemaker, it has more coils or defibrillator effect. So we will place the pads antero-posterior, try to be 8 to 10 centimeters away from the device. Also, we should have external pacing ready and set the defibrillator to synchronized mode. After achieving the cardioversion or post-cardioversion, we should assess the rhythm and hemodynamic, check pacemaker function, and integrate or reprogramming the device if necessary. Very important hint for the ICD and CRTD, we have defibrillator function. So there is no need for cardioversion, external cardioversion. But if the device not working properly, so we are in need for a magnet to stop the device and cardiovert the patient externally, and then check and reprogramming the device after the emergency condition. In this X-ray, we show a leadless pacemaker, which is present in this X-ray like that. And this is new type of pacemaker present and newly started to be inserted. In this X-ray, this is a vagus nerve stimulator, which is seen on the right side of the chest. And the generator is implanted subcutaneously in the right region. And it's coming from it, a lead come up superiorly to the right part of the neck, where it wraps around the vagus nerve in the neck, which is showed by the yellow arrow. This device using for depression or epilepsy. Sometimes it's also implanted in the left side, so it shouldn't be mixed with the cardiac devices as the leads is coming up to the neck. And in the other side, this is ICD device with its usually coils or coiled leads present. Are references of this lecture. Thank you. And I'm waiting for your comments and questions down in the comments.